So, welcome everyone. My name is Jag Gill, and I'm here on behalf of Dr. Levin to host and introduce the session today of province-wide rounds. I'd like to start by acknowledging that at least here, for those of us that are in the Vancouver and the Lower Mainland region, we're hosting this session on the unceded and ancestral territory of the Coast Salish people. That includes people in the territories of the Musqueam, the Tsleil-Waututh, the Squamish Nations, and the Métis Charter community of the Lower Mainland region. I hope each of us can reflect on the privilege it is to work and live in these lands, and reflect on opportunities to learn more about our history in whichever part of the region that we're joining from today. Now, I also like to thank our sponsors and that help kind of bring these province-wide rounds together, in addition to, of course, the collaboration between the division and BC Renal. And without further ado, I'd like to introduce Dr. Vikas Sridhar, who's going to be talking to us about repurposing therapies for cardio-renal protection and kidney disease. Tell you a little bit about Dr. Sridhar. He completed his residency training in internal medicine at McGill, and then did his residencies in adult nephrology, and then a fellowship in kidney and pancreas transplantation at the University of Toronto. Currently, Vic is a PhD candidate at the Institute of Medical Sciences at the University of Toronto, and his research focuses on, as we'll hear through his talk, on cardio-renal protection and transplantation. He's working with some great colleagues of ours, such as Dr. David Cherney. He's supported by a number of awards. He's supported by the Elliott Phillipson Clinician Scientist Training Program. He has a Banting and Best Diabetes Center postdoctoral fellowship, and a CIHR Frederick Banting and Charles Best Canada Graduate Scholarships and Doctoral Research Award. So it's a real pleasure that Vic could join us. He's in the Lower Mainland here, so we've had a great opportunity to connect with him as well. Welcome, Vic, and without further ado.
Thank you for the kind introduction. I'm just going to share my screen. Okay, good morning, everyone. Today, I'd like to share some of the work that I've been involved with over the past few years as part of my PhD training, specifically focusing on how we are repurposing therapies for cardio-renal protection in kidney disease beyond what we know so far. These are my disclosures. And I'd like to start with a few clinical cases just to bring it back to what we do. First is a 40-year-old gentleman with type 1 diabetes that we see in clinic. This gentleman is on perindopril and atorvastatin. He has an eGFR of 40 mL per minute with a urine albumin to creatinine ratio of 90 milligrams per millimole. Then we have another patient in a CKD clinic who has since progressed to end-stage kidney disease and has initiated peritoneal dialysis. She has a usual slew of comorbidities: hypertension, dyslipidemia, coronary artery disease, and is on perindopril, atorvastatin, and furosemide, and importantly continues to have about 1 liter of urine output a day as part of her residual kidney function. And then finally, we have a 67-year-old male with end-stage kidney disease due to IgA nephropathy, who is 18 months after a deceased kidney transplant with hypertension, an AV fistula, obesity, coronary disease, and like some of our other patients, is on aspirin, perindopril, indapamide, and atorvastatin. This gentleman is also on the usual triple immunosuppression with an eGFR of 40 mL per minute and a urine albumin to creatinine ratio of 5 milligrams per millimole. And the common question when I see these patients, or when we see these patients in clinic, is, beyond current management, is there anything else that we can add to improve outcomes and quality of life in these patients? So with that, that leads us to the agenda for today, which is how we are studying SGLT2 inhibition in type 1 diabetes. Also looking at it as a strategy to preserve residual kidney function and dialysis, and finally evaluating cardio-renal protective therapies in kidney transplantation. So I think everyone on this call at this point in time are acutely aware of the benefits of SGLT2 inhibition in slowing down rates of kidney progression. This is results from the SMART-C collaborative meta-analysis that demonstrates that irrespective of diabetes status, these agents do quite impressively slow down rates of kidney disease progression with the relative risk of a 0.63, and this has been shown across a range of comorbidities, a range of GFR, as well as a range of baseline albuminuria. Now, this picture over here summarizes 3 of the kidney outcome trials that have been completed. This probably should be updated to 4 clinical trials. We have EMPA-KIDNEY, Credence, DAPA-CKD, and we have SCORED as well. And what you can see across all of these kidney outcome trials that contributed to that base of evidence that demonstrated that these agents slow down kidney disease progression, that certain populations were excluded. So we excluded individuals with type 1 diabetes. We excluded individuals on baseline immunosuppression, and this would have included all kidney transplant recipients. And finally, in the top right corner, this also would have excluded anyone on dialysis. So there, it very much leaves us with gaps in our knowledge as to whether these benefits extend to these other nephrology populations. Now, focusing down on type 1 diabetes, we actually know a fair bit about the physiology of SGLT2 inhibition in type 1 diabetes. And just based on some of the work that we've done, I'll focus it on specifically the hemodynamic effects of SGLT2 inhibition in type 1 diabetes. So oftentimes, type 1 diabetes and actually many forms of chronic kidney disease are characterized by a state of baseline hyperfiltration, whether at the total kidney level or at the single nephron level. And specifically in diabetes with ambient hyperglycemia, you have increased filtration of glucose into the tubules, which actually results in increased reabsorption along with sodium. This leads to reduced distal sodium delivery, which is sensed by the macula densa. And through the process of tubuloglomerular feedback, you are left with a state of afferent dilation, which leads to that increased glomerular flow and pressures, which is deleterious in the long term. Now, the thought with SGLT2 inhibition is that by inhibiting that process of sodium and glucose reabsorption in the proximal tubule, you actually have increased distal delivery of sodium, which is then sensed by the macula densa. And once again, by restoring tubuloglomerular feedback, you're left with afferent arteriolar constriction, which in turn decreases glomerular pressures and decreases hyperfiltration and is associated with longer-term benefits, such as the hypothesis. And that also clinically manifests as an acute dip in GFR as that glomerular pressure is reduced. Now, RAS blockade also has a similar effect, but works on the other side of the equation, specifically promoting efferent dilation, but has also been associated with kidney protection in clinical trials. And these therapies are often used together. So the idea is that you have additive or potentially more than additive benefits with afferent constriction and efferent dilation, which leads to this longer-term kidney protection. And the thought is that this also may apply to individuals with type 1 diabetes and kidney disease. I love this picture, so I always throw this in, but this is actually a scanning microscope, electron microscope picture of an animal model treated with empagliflozin. And what you can see in the panel on the left over here is a relatively juicy afferent arteriole. But just 2 hours after administration of empagliflozin, you can see that the size of that vessel of the arteriole has reduced. And that contributes to that reductions in glomerular blood flow and glomerular pressures. Now, I've painted a relatively nice and simple picture, but this is probably a more complicated story than what I discussed. The whole concept of the SGLT2 inhibitors promoting afferent arteriolar constriction as the mechanism for reducing glomerular pressures has actually only been demonstrated in individuals with type 1 diabetes and hyperfiltration. When you actually go look at other populations, such as type 1 diabetes without hyperfiltration, so NF over here meaning normal filtration, as well as type 2 diabetes populations, you actually don't get such a nice picture of specifically the SGLT2 inhibition affecting the afferent arteriolar tone. It's probably a bit more complicated than that, and other author groups, including ourselves, have actually proposed that perhaps it's more of an efferent effect. It's a bit unclear as to the exact hemodynamic mechanism, but in all of these populations, you do get this effect of reducing glomerular blood flow, reducing glomerular pressures, which manifests clinically as an acute and reversible dip in GFR. Now, what about the clinical evidence for SGLT2 inhibition in type 1 diabetes? We actually know a decent amount of the effects of SGLT2 inhibitors in type 1 diabetes, but these studies are, for the most part, restricted to glycemic outcomes, so changes in A1C, typically with about a year of follow-up. In fact, there are studies with empagliflozin, dapagliflozin, as well as sotagliflozin, and I'll focus on sotagliflozin because for a variety of reasons, they are the only players in this field at this point in time. These panels over here summarize secondary analyses of the In Tandem 1 and 2 trials, which once again was a glycemic 1-year study in individuals with type 1 diabetes and importantly preserved kidney function. And what you can see in the panel at the top left is that dip in GFR that I alluded to in the pictures earlier, which is quite acute, and followed by a subsequent stabilization in GFR compared to placebo. What you can also see over here are reductions that are significant in systolic blood pressure, reductions in urine albumin to creatinine ratio among those that had elevated urine albumin to creatinine ratio at baseline. And what you can also see over here is this rise in hematocrit, which has actually been associated with conferring a significant degree of kidney protection and heart failure protection in type 2 diabetes studies, and probably reflects activation of some of the mechanisms that I discussed earlier, specifically changes in distal delivery of sodium, natriuresis, as well as restoration of tubular glomerular feedback and the dip in GFR. So we looked into this a bit more in the In Tandem 3 cohort, which is just a follow-up study of the In Tandem 1 and 2, also looking at sotagliflozin versus placebo in individuals with type 1 diabetes and, for the most part, preserved kidney function. And we zoomed in on some of those markers that have been shown to mediate clinical benefits of SGLT2 inhibitors in type 2 diabetes populations. Specifically, we looked at the effect of sotagliflozin on changes in weight, uric acid, blood pressure, urine albumin to creatinine ratio, as well as hematocrit. And what you can see over here inside the red boxes is that you do get changes that are that do reflect activation of mechanisms associated with kidney and heart protection in a very similar pattern and similar extent as what we see with SGLT2 inhibitors in other populations, which is all very promising that these agents are associated with many of the mechanisms, and hopefully this means that cardiorenal protection will be conferred in this otherwise high-risk population without a lot of existing therapies. On the other side of the equation, we have the issue of safety. So SGLT2 inhibitors are associated, we know, with an increased risk of GU infections, and this is across type 1 as well as type 2 diabetes populations. And this is, in fact, this is a meta-analysis of SGLT2 inhibitors studied in some of the type 1 diabetes studies. And what you can see, indeed, is that there's this increased risk of GU infections. The risk of urinary tract infections is neutral and is not increased with SGLT2 inhibitors. This applies to type 1 diabetics as we know it applies in other populations. Well, what I'd really like to have you focus on is this increased risk of diabetic ketoacidosis. Due to the glucosuria that is promoted by SGLT2 inhibitors, oftentimes this results in a physician-led reduction in exogenous insulin, which of course individuals with type 1 diabetes are completely reliant on, and through a series of through a biochemical cascade that's associated with those reductions in insulin as well as glucosuria, you do get an increased state of ketosis, which can sometimes manifest as clinical diabetic ketoacidosis. And indeed, what you can see over here is that this is increased in this meta-analysis of SGLT2 inhibitors in type 1 diabetes. Now, we we further evaluated this risk of diabetic ketoacidosis in individuals with type 1 diabetes, but we specifically also focus on those with CKD, which we defined relatively loosely as individuals with either a GFR of above 30 milligrams per gram or a GFR of 16 below. So not quite, not quite a high risk CKD cohort, and that's just based on the limitations of the data that we have, but certainly would be considered CKD compared to the entire cohort. And our hypothesis was that perhaps individuals with CKD may have less glucosuria with SGLT2 inhibitors, and maybe that would be associated with a lower risk of DKA. On the panel on the top, what you can see once again is that the use of sotagliflozin versus placebo is associated with a higher clinical risk of diabetic ketoacidosis. But perhaps when you zoom into the CKD cohort, this risk does not seem to be as high as the entire cohort, with the caveat that we're dealing with a secondary analysis with a small population with very low event rate numbers and quite large confidence intervals. But it does give some food for thought as to perhaps there's a lower risk of DKA in individuals with type 1 diabetes and more significant and advanced chronic kidney disease by nature of that reduced glucosuria. Now, what I haven't shown over here is that all of the other mechanisms such as weight reductions, blood pressure reductions, and urine albumin to creatinine ratio reductions are, for the most part, intact even within the CKD cohort, which is reassuring that that these mechanisms remain intact in this population. So to summarize, what we know so far about SGLT2 inhibition in type 1 diabetes is that there are reductions in A1C, reductions in blood pressure, reductions in body weight, as well as a daily insulin dose. The physiology studies suggest those reductions in renal hyperfiltration with hemoconcentration. But what we don't really know is we don't really know anything about cardiorenal protection in type 1 diabetes, as patients with type 1 diabetes and DKD have never really been studied in any meaningful way. So we are very much interested in rectifying this situation, and under the leadership of David Cherney, we will be initiating the sugar and salt trial, which has two aims. One is to determine the effectiveness of sotagliflozin in slowing down eGFR decline in persons with type 1 diabetes and moderate to advanced diabetic kidney disease. And at the same time, and in my opinion, equally important, is to institute and assess the feasibility of a diabetic ketoacidosis mitigation protocol to ensure that in addition to the clinical benefits of SGLT2 inhibitions, we also do so in a safe manner that manages that risk of DKA. So this study, it will involve 150 individuals that after run-in period will be randomized to sotagliflozin 200 milligrams or placebo, and they'll be followed for a period of 3 years, at which point in time there'll be a 2-month washout period, and eGFRs will be measured at that point in time. Now, I've been talking a lot about sotagliflozin. I just and we may not all be familiar with this agent as it isn't available here, but we know about the beneficial effects of sotagliflozin in the SCORED trial, which is the fourth of the kidney outcome trials that was published a few years ago, and I recently published the results of the renal analysis of the SCORED trial. And what you can see over here is that sotagliflozin, which is an SGLT1 and 2 inhibitor, irrespective of the endpoint that you look at, whether it's an eGFR decline of 57% with or without cardiovascular outcomes, as well as 50% and 40% eGFR declines, what you can see is quite consistently that sotagliflozin is superior to placebo with hazard ratios that are quite comparable to what we've seen in the other kidney outcome trials. Now, coming back to the sugar and salt trial, the key inclusion criteria over here is that these individuals with type 1 diabetes with an eGFR of 20 to 60 mils per minute and a urine albumin to creatinine ratio of at least 200 milligrams per gram. So this is quite a high risk cohort. And the primary outcome is an eGFR creatinine cystatin C after an 8-week drug washout, specifically the average of those 2 readings that are done at the end of the drug washout. And the reason we picked that outcome is we felt that this was the best way to account for that acute eGFR decline that does occur on initial initiation of the medication. We're looking at a number of secondary outcomes, including our more classical kidney composite outcomes, changes in eGFR slope and albuminuria, as well as cardiovascular outcomes. And as I mentioned earlier, an important part is very much the validation of the diabetic ketoacidosis mitigation strategy and looking at the safety of these agents as well. Coming back to our case then, so a 40-year-old individual with type 1 diabetes, an eGFR 40 mils per minute, and a urine albumine creatinine ratio of 90 milligrams per millimole. I think we would all agree that this is a high-risk individual. However, at this point in time, despite that, we do not have any guideline-recommended therapies. Hopefully, with the results of sugar and salt trial, as well as other trials that we are currently involved with, including agents such as finerenone, as well as GLP-1 receptor agonists, we can start to involve these patients in some of these trials. And I would like to say that the sugar and salt trial, when it does begin recruiting, UBC is very much an important part of that trial, and Vancouver will be recruiting for that study as well. So it's something that we're very excited about. So moving on in our agenda, I'd like to discuss evaluating SGLT2 inhibitors as a strategy to preserve residual kidney function in dialysis. I think nephrologists have known for some time now that residual kidney function is important. And specifically, it's the residual urine volume that appears to be the most important, as first demonstrated by Dr. Bargman several years ago, and more recently in the CJASN study in 2017. And what you can see over here, when you look at the adjusted hazard ratio for mortality, urine volume, specifically urine volume per 100 cc's per day. So for every 100 cc's of urine output you have per day or more, this is the variable that is associated with a reduced risk of mortality across a number of subgroups. So when you look at those with urine volume more than 100 cc's per day, we're looking at those on hemodialysis, those on peritoneal dialysis, those with less than or greater than 2 years of dialysis vintage. Across all of these, you can see consistently that urine volume appears to be important, specifically the presence of urine volume for every 100 cc's. We know that urine volume is important, but we don't have too much by way of therapies to preserve this residual urine volume. This slide is from the results of a meta-analysis that was published several years ago, more than 10 years ago at this point in time. And what it does suggest is that perhaps the use of ACE inhibitors and ARBs may be associated with some degree of preservation of this urine volume. However, the caveat here is that these were small studies without the longest duration of observation. So it's unclear as to how effective these therapies actually are in terms of preserving residual urine volume. Now, what about SGLT2 inhibitors? I think there's actually a strong rationale for the use of these agents to preserve residual kidney function and for cardiovascular protection in peritoneal dialysis patients. So there's, we're all aware of the cardiovascular protection with SGLT2 inhibitors, which the hypothesis is that this may also be the case in those in peritoneal dialysis. There's also the concept of kidney protection. Individuals on dialysis with residual kidney function may have 3 or 4 or 5 glomeruli that are doing all of the work and probably are experiencing a significant degree of glomerular hyperfiltration. Perhaps the SGLT2 inhibitor, by reducing that hyperfiltration, as well as the other pathways like effects on inflammation and fibrosis, may contribute to the preservation of those last remaining nephrons. And also intriguing is the effects of SGLT2 inhibitors on glucose transport within the peritoneal membrane. There were a series of studies that demonstrated in animal models, perhaps some evidence of SGLT2 expression in the peritoneum, and perhaps in some animal models that there may have been some beneficial effects on transport. More recently, this seems to not be the case in subsequent animal models that were published in JASN, where the SGLT2 inhibitors did not seem to have an effect on glucose transport. But certainly we do not have a lot of data in humans. And all of these do contribute to a rationale for using or at least studying these agents in PD patients. So we are currently involved with a mechanistic study, and this is the CANARY study, where we're looking at peritoneal dialysis patients with residual kidney function measured by residual urine volume, with or without diabetes. And it's a very short study. It's just a 2-week study We currently are planning for 20 patients, although we're currently in discussion with a few other sites to actually hopefully triple this number. We recently received some additional funding, and the goal of the study is very much to demonstrate that some of the mechanisms that are associated with kidney protection in other populations are also intact in a peritoneal dialysis population with residual kidney function. And the way the study works is that individuals undergo a baseline visit where they have a baseline 24-hour measured GFR. That's an average of creatinine and urea. We also do a baseline PET as well as a series of other mechanistic biomarker and biosampling-based assays. And then we start them on the medication for just 2 weeks. We bring them back 2 weeks later, and we measure all of those things again. And then we have a washout visit at week 4 where we do an off-drug GFR. And this study is just powered around a dip in GFR after 2 weeks of initiating this medication, and then a subsequent rebound in GFR after that. The idea being, if you are able to demonstrate those acute changes in GFR, perhaps that is demonstrative that you have some of those tubular glomerular feedback mechanisms that are intact in this population. So coming back to the individual in CKD clinic that has progressed to end-stage kidney disease and has been started on peritoneal dialysis, but continues to have residual urine output, I think time will tell. Our hope, our goal is that with some of the preliminary data that Canary generates, we'll actually be able to leverage that to apply for more grant funding to actually do something longer term and generate some results. So finally, something that is near and dear to my heart is evaluating cardiorenal protective therapies in kidney transplantation. I think we can all agree that there's really a important need for new cardiorenal protective strategies in transplant recipients. These figures over here demonstrate that while there have been improvements in our more so short-term outcomes as opposed to long-term outcomes, for the most part, we seem to have plateaued in terms of subsequent improvements in especially 5 and 10-year graft survival. And the other thing with graft loss in kidney transplant recipients is that important cause of graft failure is what we call death with a functioning graft, where the individual dies due to other etiologies. And in those individuals, oftentimes, the most important cause of death is cardiovascular death. So cardiorenal issues remain a huge issue in this population, and we do not have any established therapies to actually modify that risk. Now, we are, of course, interested in studying the mechanisms of studying SGLT2 inhibitions in kidney transplant recipients, and I am particularly interested in evaluating those mechanisms of SGLT2 inhibitors in kidney transplant recipients. The kidney transplant actually is quite unique in that you have a very defined period of insult, which is when we have implantation of the allograft. And what our collaborators have actually demonstrated is that within 1 year of the transplant process, you actually have upregulation of pathways that are associated with hyperfiltration, hypertrophy, as well as adverse activation of adverse metabolic and inflammatory pathways. And as I mentioned earlier, cardiovascular disease also is an important issue, specifically leading to this premature graft loss with death with graft function. Now, as we all know, SGLT2 inhibitors are able to target each and one of those pathways, which makes for a very strong rationale to target these pathways and perhaps modify subsequent mortality and morbidity in kidney transplant recipients. So as part of my my PhD, I've been leading the Infinity study. This is a mechanistic study of dapagliflozin versus placebo in individuals with a stable kidney transplant. This study was originally designed to include individuals only with type 2 diabetes or PTDM, post-transplant diabetes. But since then, we have actually amended it to include individuals with and without type 2 diabetes. Our sample size is 52, which is quite typical for our more mechanistic and physiology-based studies, and as is the observation period of 12 weeks. That's a fairly simple inclusion criteria. We're looking at individuals with an eGFR of at least 30 mils per minute, and they need to be 6 months after transplant. And it's powered around a primary outcome of blood pressure reduction But importantly, being a mechanistic study, are several secondary outcomes, including metabolic factors, vascular factors, including changes in renal blood flow, measured GFR with iohexol, arterial stiffness, echocardiographic parameters, as well as safety parameters, and a biomarker analysis that is funded by the UHN Ajmer Transplant Center. The goal over here of the study is very much to look at the several mechanistic pathways and see if they are modified by SGLT2 inhibition versus placebo. And the goal being that if we're able to demonstrate that these mechanisms are intact in the kidney transplant recipients, this strengthens the rationale that these agents would confer cardiorenal protection in this population without a lot of other therapies. In terms of the progress, we are actually quite close to completing the study. I actually need one more individual to be randomized into the study, and hopefully this will occur in the near future. So we are quite close with quite a good balance of individuals with type 2 diabetes and without diabetes. Switching gears, I'm also very interested in evaluating GLP-1 receptor agonists in kidney transplant recipients. I think many of us may have seen recent announcements towards the end of last year and more recently that the FLOW trial, this is the renal outcome trial with semaglutide in individuals with type 2 diabetes, CKD, specifically with albuminuria. This study was actually stopped early in October, and then they announced the top-line results in March that there was a 24% reduction in that composite kidney outcome. So these results are probably going to be published in the next month or so. It's very exciting, and this will add to the armamentarium that we have to treat diabetic kidney disease. Now, what about the use of these agents in transplant? I'm specifically involved in the SPOT-DM study, where we're looking at semaglutide to actually prevent post-transplant diabetes in kidney transplant recipients. We actually have known for quite some time that GLP-1 receptor agonists actually prevent diabetes. This is the results of the SCALE program published in 2017. And in the top panel, what you can see is that over time, you actually have a reduction in the number of individuals with diabetes. And you can see over here that that's liraglutide at the bottom and placebo on the top. And in the panel below, they specifically looked at individuals with pre-diabetes, and what they observed over time, that those treated with liraglutide actually had a higher rate of reversal back to normal glycemia versus those on the placebo. I would direct your attention to what happens when these individuals are off the drug. What you note over here is that the curves seem to go back together, perhaps suggesting that once you're off the medication, you revert back to your pre-existing glycemic phenotype. These results have also been demonstrated with semaglutide and are actually being evaluated as part of the STEP 10 program more formally. We also recently have the results of the SELECT trial, which looked at individuals with obesity, cardiovascular risk factors, but without diabetes. What you can see over here is that semaglutide was very effective in terms of reducing the risk of the primary cardiovascular composite outcome, as well as a few other outcomes, including all-cause mortality. So with everything that we know about GLP-1 receptor agonists in non-transplant populations, what about the kidney transplant recipients? Kidney transplant recipients are at increased risk of PTDM for two reasons. Number one is that they have the whole slew of pre-transplant risk factors such as age, obesity, genetic backgrounds, dyslipidemia, and then you throw on the transplant-related factors such as immunosuppressive drugs, which may lead to some beta cell toxicity. You have viral infections and hypomagnesemia, which are hypothesized to also contribute to that risk of insulin resistance or beta cell dysfunction. And all of those together contribute to mechanisms that ultimately lead to post-transplant diabetes. The incidence of post-transplant diabetes is variable, depending on which study that you look at, but it's been demonstrated to be as high as 1 in 4 kidney transplant recipients actually going on to develop a PTDM, particularly within the first few years after transplant. So this is the SPOT-DM study that I mentioned earlier. So this is another mechanistic study with 50 individuals. We're specifically looking at kidney transplant recipients early after transplantation that are at risk for PTDM. We define that based on BMI of above 27, an abnormal A1C or an abnormal OGTT. So if they have one of those, they are at risk for PTDM, but they do not yet have PTDM. And then we subsequently randomize them to either semaglutide or a placebo, and we observe them for a period of 48 weeks. We're also interested in following these individuals after the study drug period. So after the 48-week period, we have a observation period to see what exactly happens to these individuals when they're all taken off the medication. Do we simply delay PTDM, or is there more sustained effect even after the drug is discontinued? So this is, we're looking at individuals with an eGFR of 25 mils per minute that are at risk of PTDM, and we want to catch them quite early after transplant, as soon as between 4 and 12 weeks post-transplant. The primary outcome is actually a change in blood glucose at 120 minutes. So that's the 2-hour OGTT test that we'll do at the end of the 48-week period. And we're looking at a number of secondary outcomes, including metabolic outcomes, renal outcomes, and vascular outcomes. And specifically, for the first time, to my knowledge, we're actually incorporating the use of MRI, specifically bold MRI protocols, to actually look at changes in renal perfusion, cortical fibrosis, as well as renal oxygenation. We're also looking at a number of biomarkers as well. So this study was recently funded by Diabetes Canada, and we're very excited to get the study initiated. And hopefully some of the information that we glean from this study may inform future grant applications and future prospective clinical outcome studies. So the goal of all of these mechanistic studies that I've been discussing is ultimately to inform a clinical outcome trial in kidney transplant recipients. There are actually a lot of challenges, unfortunately, in planning cardiovascular and kidney outcome trials in kidney transplant recipients. Number one being to adequately power any of these studies, we need a large sample size to detect significant changes in the primary clinical endpoint. A lot of the studies that I discussed earlier in this talk, such as Credence, EMPA-KIDNEY, and DAPA-CKD, had sample sizes in the ranges of 3,000 to 5,000 individuals. The largest clinical trial in transplant patients is probably the Elite Symphony trial, and we're dealing with about 1,700 participants in that trial. So there's a huge discrepancy in the populations, in the general CKD population and the kidney transplant population. So that means that we need to come up with more creative ways to design these studies. And part of that includes picking a reasonable clinical outcome. So whether that's a composite of cardiovascular and kidney allograft outcomes, whether it's picking an adequate percentage of decline in GFR that allows for a reasonable sample size, these are all considerations. Whether we look at more creative factorial or platform-based clinical trials versus a more traditional clinical trial. So these are all considerations to try to surmount the challenges in planning cardiovascular and kidney outcome trials in the transplant population. I'll specifically focus on how much of a GFR decline is sufficient to design a study around. Now, this picture over here was published in 2014 and very much guides nephrology clinical trial design in general CKD populations. And what you can see over here in the top panel is that in the x-axis over here, you have the percentage change in eGFR over a 3-year observation period, and then the associated hazard ratio. And what you can see is when you look at something like a doubling of kidney function loss, which is roughly a 57% decline in eGFR, this is associated with an adjusted hazard ratio that is well above 100. And when you go look at more lower changes in GFR, such as 40% decline in GFR, this is associated with roughly a hazard ratio, adjusted hazard ratio of 10. And the reason why we may pick a 40% decline in GFR versus a 50% decline in GFR is that when you go look at the panel below, a 40% decline in GFR is significantly more common than a 57% decline in GFR. So you would need a smaller population, which is why increasingly we see the use of a 40% decline in GFR in renal composite outcomes in clinical trials. Now, we actually have this data in the transplant population as well, and it was published in several years ago in 2016. And what you can see over here quite similarly is that you have the percentage change in GFR and the associations with hazard ratios of death, graft failure, and death-censored graft failure. And what you can see is that, once again, even something like a 40% decline in GFR, or even for that matter, a 30% decline in GFR is associated with quite high hazard ratios, reasonably high hazard ratios for things like patient death, graft failure, as well as death-censored graft failure. Now, I'd like to switch to the Renaissance trial, which is actually our proposed cardiovascular and kidney outcome trial in SGLT2 inhibitors in kidney transplant recipients. And this is something that I've had the privilege of being a part of for the past several years. Now, this proposed trial has a quite liberal inclusion criteria. So we're just looking at individuals with a GFR of above 20 mils per minute, and they need to be at least 6 months after transplant. And what the steering committee decided upon was a hierarchical primary outcome, which is what we call a MACER outcome. So that's major adverse cardiac and renal function outcomes. And this ends up being what's called a hierarchical primary outcome. And what we end up doing over here is something I had to read up around to really wrap my head around, is that you have your study population that is randomized to either treatment with a study drug, in this case an SGLT2 inhibitor, or a placebo. And what you end up doing is that you compare every possible treatment and placebo pair. And what you do is you try to generate what's called a win-loss ratio. So what you do in these pairwise comparisons is that over the observation period, you look at which individual in the pair had all-cause mortality occur first. And if neither of the individuals in the pair end up having the first outcome, you move down to the second outcome, which is allograft loss. And you see over the observation period if any of the individuals in the pair end up having this outcome. And if they don't have this outcome, you end up moving down to number 3, and you keep moving down to number 4. Now, 1 to 5 are all dichotomous outcomes. You either have it or you don't over the period of observation. So what that means is you're going to need a tiebreaker, and the tiebreaker in this case would be eGFR slope. So at the end of the observation period, which one in the pair had a higher eGFR decline? And based on that, you're able to generate a winner or loser. And you do this for every possible treatment and placebo comparison, so every possible combination. And what you ultimately end up comparing is the percentage of winners in the treatment group divided by the percentage of losers in the treatment group. And that ends up generating what's called a win-loss ratio, which can then subsequently be converted to a hazard ratio. Now, the advantage of this outcome is that it allows for a more efficient sample size. And also importantly, it also incorporates the importance of clinical outcomes within the composite. And this is something that we actually had input from patient partners as to what they felt was a more important versus a less important adverse outcome. And they very much helped guide the trial design in this case. So where are we right now with Renaissance? So based on the methods that I discussed in the previous section, we came up with a sample size of 900 participants with a follow-up period of 48 months after an enrollment period of 18 months. Right now, we are actually, we recently submitted a grant to apply for another grant. So this is the U34 grant mechanism, which if we're successful would fund us to actually plan and design the study, which would be another grant that we would ultimately apply for. So, and it's something that we're excited about. And we do have several other stakeholders as well that have been aiding with study design as well. So coming back to case 3 that we have over here, the transplant recipient with IgA nephropathy with an eGFR 40 and a urine albumin creatinine ratio of 5 milligrams per millimole. It's very similar to the type 1 diabetes situation where, unfortunately, at this point in time, we do not have additional therapies to add, but hopefully with time, as we start to get some of the, as we eventually get some of our clinical trials off the ground, this may change. So with that, I'd like to conclude with a few future directions, which importantly includes wrapping up my PhD. I'm also very interested in developing new mechanistic techniques, especially working more with MRI-based techniques and incorporating that into mechanistic clinical trial design. I also have a few additional renal analyses for the SCORE trial that I'm leading and I need to complete. And the other thing, thinking forward, is using these mechanistic and clinical trials as a model to study other agents in kidney transplant recipients, such as incretin therapies, finerenone therapies, endothelin receptor antagonists, as well as aldosterone synthase inhibitors that are around the corner and will probably be used to a great extent in the CKD population. And with that, I'd like to thank all of my collaborators, my funders, as well as the members of my thesis committee. Thank you.
Thanks very much, Vic. That was an excellent presentation, and congratulations on all the great work that you've been involved in. We have about 10 minutes to open it up for questions, so people can put up their hands. They can put questions in the Q&A. But maybe while people get organized, Vic, I'll just ask you a quick question. I'm very interested by the mechanistic studies you've been involved in, and how you've kind of leveraged that as a good starting point to filter through to clinical trials. You talked a bit about the challenges, obviously, in the kidney transplant realm, for instance, that we're facing with clinical trials and how we get there. Could you speak a little bit with those mechanistic studies, how you see those playing an important role in the future in kidney transplant research, and maybe some of the challenges that you faced along those lines?
Yeah, that's a great question. I'm probably one of the largest proponents of good clinical trial design to actually guide practice. So I'm very cognizant that a mechanistic study, no matter how positive or impressive the results are not necessarily going to change guidelines and influence practice. However, I still think there's a very important role for mechanistic trials. Number one being is that if we demonstrate that these mechanisms are intact in this population, I think it's a very, very important preliminary data that we can then leverage for grant applications to actually design and fund a clinical trial. Unfortunately, for a variety of reasons, when we're planning these clinical trials in transplant populations, we end up being reliant on public funders, whether it's NIH or CIHR. So this preliminary data, I think, is very important. I think the other reason why these mechanistic studies are important is that when you have 5 or 6 different therapies, it very much allows us to focus on 1 or 2 that we are very much able to demonstrate robust activation of mechanisms, and that perhaps allows us to focus on one therapy versus the other. And the other thing with these mechanistic studies is that it may also eventually lead to important preclinical data that may have other downstream effects and lead to other avenues of investigation. So I think there are merits to these mechanistic studies, but I think the purpose of our lab has always been to use these studies to then guide, inform, and obtain funding for future larger clinical trials.
Thanks, Vic. Yeah, no, I think it is. I think it does play an important role as we're moving forward in terms of, when I think about the transplant piece, you highlighted a number of important limitations, right? The key one, obviously, being that when we're trying to look at sample size and how we have to be creative in terms of outcome measures. The other limiting factor, or the other way to tackle that limiting factor, is important collaborations, whether they're national or international. We're not a huge country, but we do have the ability, I think, to partner with a lot of people around the world and create networks. Have you been involved or had experience with any of those, or just your thoughts on how you see that evolving?
Yeah, I think the only way to move this forward is with collaboration, and I think we have a very strong close-knit community in Canada, but we also have really good collaborations with the international players as well. And that's the one thing I learned from working with the Renaissance trial group and the steering committee, is that there are so many passionate, highly accomplished individuals in the United States, in Australia, in Europe, that are willing to work together on this effort. So, the Renaissance steering committee is actually being led by Dr. Arthur Mattis out of Minnesota, but there's almost every large institution over there is involved. We have pan-Canadian involvement as well, and a lot of interest from Australia as well. So and Europe as well. So I think the most meaningful way to move forward in this is not to go it alone, and I think it's very much a team effort. Once again, because of the limitations of, our field. There aren't large numbers of transplant recipients, so I think you need to look outside Canada, and you need to look at multiple centers, and you need to look at pragmatic ways to actually conduct these studies, recruit quickly, and actually get some results that will change practice.
Great, thank you. There's just a question from one of our transplant colleagues, Matt Kaditz. Matt says, "Thanks, Vic, for the talk and a great body of work. While we wait for the results of these studies in transplant patients, what are your thoughts about SGLT2 inhibition in transplant patients who have other indications such as heart failure, et cetera? How would you be counseling those patients?"
Yeah, so this comes across all the time. Of everyone's asking this in a variety of ways. So in my clinical practice, if I have a kidney transplant recipient with whatever comorbidities, I tend to not start these agents at this point in time. However, what more often ends up happening is we are approached by, let's say, the cardiologist. They have a kidney transplant recipient with heart failure, whether it's half ref or half PEF, and they would like to start an SGLT2 inhibitor. And what they usually end up asking us is if we have any opposition. And usually what we will say is no, go ahead. We'll monitor kidney function. We'll continue to follow the patient. The endocrinologists sometimes approach us as well. They have a patient with type 2 diabetes and a history of coronary artery disease, which in the general population would be a class 1 indication to start these agents. And they ask, we would like to start this medication. What are your thoughts? This patient is also obese. They also have other comorbidities. And usually we end up saying no. So for those indications, when there are other specialists involved and they ask our input, we usually end up saying go ahead. The gap is when you have the kidney transplant recipient with an eGFR of 25, with or without proteinuria, and they have this like slow grumbling decline of the last few years. Do we start them on an SGLT2 inhibitor for kidney protection? I think that's a question mark, and that's something that I'm not currently doing. I don't know what other people are doing, but I think we would all agree that there is equipoise with patient from a patient and a physician standpoint as well. And I think that equipoise is very much why we need to do a study to examine questions like that. The other thing is that you're going to start to get this indication creep where you're going to have this general CKD practices creeping into transplant practice, and you may end up having more slowly but surely more and more people being put on these medications. And then we are in a situation where you may have like 40% or 30% of kidney transplant recipients on an SGLT2 inhibitor, and you don't necessarily have the body of evidence to support it, and you don't really know if is it futile, is it beneficial, what is the risk benefit ratio, and those would all be questions that are unanswered. So I think we just need more data before we use these agents widely.
Thanks, Vic. No, I completely agree with you. I think we saw that with the RAS blockade, where that creep happens, and then you question the equipoise. And so I think the time is now to really do that. But I see we're coming up to the end, and I want to thank you again, Vikas, for your time and congratulate you again on the great work you're doing. Hope to see more of you soon.
Thank you.
Thanks, everyone.